Morning. Away you go. See you.
All right. Hey guys, I'm Theo. I'm project entitled Automated Lesion Tracking and Dual Tracer PET Biomarkers and Prostate Cancer. So hopefully I don't tie you with too many preliminaries, but they have to be set to contextualize research. So prostate cancer, as we know, poses a quite significant financial burden on society and of course for the patients themselves. Now, after we've diagnosed and established the presence of the cancer, one of the first critical steps in clinically managing it is staging. So this refers to determining the extent anatomically of the disease, and this allows us to group the cancer in these various categories, whether it's localized, more advanced, or metastatic. Now, within these categories, there's another staging category called biochemical recurrence, which occurs when the patient's PSA levels, so PSA is a protein found in the blood, is elevated following either radiotherapy or surgery. And I've highlighted these two stages in red because they're going to be relevant to the cohorts that we use in the research. So then a natural question arises, well, how do we actually determine these various stages? Well, imaging. And traditionally this has been done with bone scintigraphy and SPECT CT scans. But as we all know, PSMA has been discovered to be a protein overly expressed on prostate cancer tumor cells, and that's allowed it to be used as a target for radioisotopes to be attached to, delivered to the patient, and used for diagnostic purposes. And of course, in contrast, we can also attach it to something like lutetium-177, which is going to deliver beta radiation to tumor sites. So, still within the context of PSMA, we need to set up this additional ingredient to understand research. So, here we're talking about if a patient undergoes therapy and specifically undergoes PSMA imaging before and after the therapy. Sorry, that's all good.
Just covering up some of the slides.
Yeah, sure. So how do we determine quantitatively a patient's response to a treatment if they've undergone with the use of PSMA imaging? This is where this thing called RECIP comes in, which allows us, the clinician, to group the patient in one of four categories, depending on changes in total tumor burden from baseline to follow-up scans, and also the appearance of new lesions. And so I've said this here because it will come back a bit later on. So this is a way to evaluate treatment response. Now, another modality that's used to actually image prostate cancer and stage it is FDG. Now, FDG PET is much less commonly used for prostate cancer because when the cancer is at an early disease stage, it doesn't tend to uptake much glucose. FDG being a glucose analog, it's not going to be useful. But as it turns out, as the tumors progress and become more aggressive, they actually tend to depend increasingly on this thing called aerobic glycolysis, which is basically glucose metabolism, which allows us to use FDG to image the cancer. And if we think about that, then that means that, and studies are showing that patients who tend to exhibit FDG uptake compared to those without tend to have worse survival probabilities because it's indicative of a much more aggressive tumor type. And this kind of leads us to this phenomenon, considering both modalities, called discordance. And this is quite simple. It just occurs when a patient's undergone an FDG PSMA scan, and on an FDG scan, we see lesions that don't appear on their corresponding PSMA scans. If you look in the middle, for example, all the red dots are FDG discordant lesions, and this is pretty bad for the patient because usually at this stage, they're going to undergo lutetium PSMA therapy, which is a PSMA-based therapy. And so all those red sites are not going to be able to be targeted by that therapy. And so usually when a patient exhibits discordance, it's prognostical of much worse outcome, as we'll also see in the next slide. And so this actually sets everything that we need to sort of understand the aims of the research. So first of all, it's going to be to explore basically that discordance. So in this short literature review, one of the first things that we note is that a lot of the papers have shown that just the presence of a single mismatch lesion, so a single discordant lesion, tends to is prognostical of much worse overall survival. So the first stage is sort of just going to be to evaluate the impact of the discordance on patient outcome, because this hasn't been done and established much in the literature. The second sort of thing is if we look how discordance is actually assessed and defined, how are these mismatch lesions discovered, it's done primarily with visual reads. So that means clinician will take an FDG PSMA scan and qualitatively determine if and where discordant lesions are. So broadly speaking, that will be to investigate the impact of discordance, as I've said, and these two latter points will be to sort of quantify the assessment of discordance. So are there quantitative metrics we can use to define discordance in a more quantitative way, as opposed to a qualitative analysis? And along with this, of course, we'll find a way to automate the detection of that discordance and get into that later. Now, the second aim, which was the original aim of the research, was going to be to validate that criteria I talked about before. But quite early on in the research, what I realized was that across these 4 categories, so to determine what category the patient's going to fall in, we need to determine the appearance of new lesions. And as it turns out, in the data set I was handed, there was no lesion correspondence between time points. So I had no way to actually determine if a patient had a new lesion on their scan or not. So that led me to basically scrap that entire aim and focus on this new aim, which was to use and validate an existing lesion tracking algorithm. Lesion tracking is going to establish that lesion correspondence, and it's going to tell me, it's going to enable me to know if a patient has a new lesion, and therefore we're going to be able to demonstrate its utility in a response evaluation framework, namely RECIP. So this will probably make more sense in 2-3 slides. All right, so let's actually get into that first of all. So lesion tracking. So for this, the algorithm that was used and validated on, it was on a cohort of biochemically recurrent patients who had undergone gallium-68 PSMA imaging before and after various therapies. Now, after some form of filtering process, we were left with 132 patients. So 132 pairs of baseline and follow-up scans, across which were over 1,000 individual lesions. To build the ground truth, so we could evaluate the performance of the algorithm, every unique lesion was assigned a label. So it was either considered new, disappearing, or corresponding. And what I mean by corresponding is if there were 2 individual lesions on 2 scans that were actually identical to one another, those 2 lesions were assigned one unique label. And so what this led to was a total of 695 so-called reference matching decisions that could be utilized to validate the algorithm. Right, so quick methodology of the actual algorithm used. So all credit to the group in Wisconsin whose method I basically emulated and modified slightly, and I'll tell you where I modified it. So in the first step, what we did was co-register the follow-up scan to the baseline scan in order to bring the 2 segmentation maps onto one common plane, as we see on the PET scan there. And then these 2 overlaid segmentation maps were dilated. So what this means is increase in size, essentially. And this was done in 2 ways. So by applying this formula, which is really small on the screen, but this is called an automatic dilation. So it's going to look at every lesion and assign a dilation-specific radius to every lesion. And also experimented was applying fixed dilation radius. So for example, increasing every lesion by 3 millimeters, let's say, morphologically in every direction as well. And then importantly, using these 2 overlaid dilation segmentation maps, various cost functions were built. So this is where we differ a bit from the Wisconsin University, where what they did was, considering the 2 overlaid segmentation maps, they built this variant A cost function. So what they did was just computing the raw voxel intersection between every lesion pair on the 2 overlaid segmentation maps and put that in a cost function, which will be optimized later on. But what I wanted to experiment with was, are there other ways to inform us of the correspondence between lesion pairs? So for example, if you look at the variant A dash, which will come up later, what we're doing is actually computing the fractional overlap between lesion pairs. So asking how much does the small lesion, does a small lesion overlap with a bigger lesion, okay? And for example, variant C is actually just going to calculate the central distances between lesion pairs. And this makes sense if we consider that the next step is to actually optimize that cost matrix. So if we optimize variant A, we're actually maximizing basically the volume overlap between lesions and then making matching decisions from that. And so basically for the 132 patients, I was able to get information regarding corresponding new and disparate lesions. And as I've said before, taking that critical information regarding new lesions, asking, okay, well, does this patient show a new lesion according to our algorithm or not, which would then lead to that downstream RECIP classification. So then we could get a classification accuracy within, using this algorithm. Okay, so some preliminary sort of performance of the algorithm. So across the 4 variants and under automatic dilation, we achieved the best matching accuracy for the variant A-. So that's using the fractional overlay with 95.1% accuracy. And then actually looking at all the matching decisions in a bit more detail. So asking, was this decision, did it incorrectly classify a corresponding lesion as a new lesion, etc. We were able to build confusion matrices and basically plot precision and recall curves across the 3 unique lesion category. And what this is telling us here is, for example, that the algorithm was the most sensitive at determining new lesions. Okay, and this just gave us a better insight into the strength and weakness of the algorithm at determining these 3 individual categories, which, depending on the clinical application, you might want to, have an algorithm that's better, have better precision at determining corresponding lesions, for example. There's just a, then in the second analysis, a so-called sort of dilation sensitivity analysis was performed. So this is actually tweaking the dilation radius which we did in 3 millimeter steps from 0 to 18 millimeters. What we see is that the accuracy is the worst when no dilation is used. So it increases, plateaus, and goes back down again. What that's telling us is that with no dilation, we're essentially only relying on the registration process, which is bad. But when we have too much dilation, obviously we're overshooting the volume of the lesions too much, and then the matching is not going to be as accurate, I guess. And this sort of analysis was repeated across the 3 lesion categories. So asking, how does precision and sensitivity at determining, for example, new lesion vary as a function of dilation radius? And then taking the information, especially with the automatic dilation within RECIP, of the 132 patients, 31 had at least 1 new lesion on follow-up scans. And after computing some volume changes between the baseline and follow-up, we were able to plot a confusion matrix showing the ground truth RECIP classification with respect to essentially the algorithmic RECIP classification, which, as we see, there were actually 6 misclassified patients if we use the tracking algorithm. So what that led us to was a 95.5% classification accuracy when using the tracking algorithm to determine the appearance of new lesions. All right, then sort of lastly, I wanted to find a way to quantitatively analyze the actual mistakes made by the algorithm. So of those 695 decisions, 34 were incorrect. So 4 categories of variables were tested for this. So first of all, registration quality. So I computed normalized cross-correlation coefficient and mean squared error, which is sort of ways to assess the linear intensity differences. And what was seen was, so I computed one value for the 132 patients and then divided those into quartiles. And in every quartile, I asked how many errors were made in that quartile. So what I mean by this is, for example, for the NCC, in the lowest quartile, so anything below 96%, there was an error rate of 10.8%. Whereas in the higher quartiles, which represent data registration, the error rates dropped to 1.2 to 3.5%. So what it's telling us is that there's a 2 to 10 times error rate risk increase for the scans with poor registration. And the same idea was shown by the MSE. Again, the same idea was done, but asking the lesion size. So did smaller lesions have a greater likelihood of being mismatched? And this can be expected because of registration misalignments and And what it was found was that there was no real significant differences between the error rate groups. I didn't include the statistical test for this, but I compared them with Mann-Whitney U-test. And yeah, so there was no significant difference. And then finally, and quite importantly, I asked, did those patients who had more lesions on their scan tend to have more mismatch errors? And what it was found was that no, basically there was no real difference in the quartile groups. And what that's telling us is that basically the algorithm was as robust at making matching decisions in high burden cases as it was in lower burden cases. And then finally, and I'll go through this quickly, I basically also tested in specific anatomical sites, was the likelihood of making a matching decision, a mistake, was that higher? Basically what this is telling us is there was no statistical significant difference in any of the anatomical sites. So really, takeaways that the registration quality was the dominant driver of mistakes. Now, this was also, for completeness sake, put into a graphical user interface. And this sort of just shows the way that we can streamline the RECIP classification by, first of all, running the algorithm, and then getting that automatic RECIP classification. So it was a way to show we can streamline the automation of the classification. Now, in terms of discussion, so we can briefly compare the matching accuracy that we actually got. So it was hard to find in the literature exact matching accuracies for a lot of papers. But if we look at a couple, in the deep learning world, the matching accuracies actually tend to be lower than 90%. Now, maybe I missed some of the papers, but those were the numbers reported. And importantly, the Santoro Fernandez set up. So this is the group from which I emulated the method. In their original paper, they actually achieved 98% matching accuracy, but this was done with a 25mm dilation. And so what I think happened is that likely overfitted to their data set, as what we found was that the higher the dilation radius, the poorer the accuracy. So as a brief summary here, so the most important bits are that the performance was independent of the total lesion count. This is useful so we can use it in high disease cohorts. Second of all, this fractional overlap, as opposed to just computing pure volumetric overlap, seemed to improve the performance, but only by 1%. So it's not significantly different. And third of all, there was that novelty of propagating the lesion tracking information in RECIP specifically. So limitations, we kind of seem to see a convergence at about 95%. And I tweaked some other things, but wasn't really able to get much further than that. So on top of the registration, I do think that there is inherent inter-observer variability. So that can't really be gotten rid of. And then second of all to note is that any tracking algorithm using registration is going to be inherently susceptible to registration misalignments and inaccuracies, which oftentimes can't be handled very easily. And in terms of the future work, it'd be really interesting to make that registration process probabilistic, such that we can produce sort of a voxel-wise uncertainty map. And so every matching decision would actually come with an uncertainty metric, right? How certain is it that this decision was correct? And that uncertainty could be propagated into the RECIP classification. So that could be an interesting path to take. And then, of course, and what I'll probably do for the future paper, just coming, is to apply the lesion tracking information in other contexts. So, for example, PPP is like RECIP, it's another response evaluation framework, and see how those classifications would differ with the use of the tracking algorithm. So that's lesion tracking done. So now exploring that discordance. So for this, a separate data set was used, which consisted of 49 metastatic castration-resistant prostate cancer patients who had undergone PSMA and FDG imaging before their first cycle of lutetium PSMA therapy. So as I said, we want to quantify and automate the detection of discordance. So to do this, two somewhat novel approaches were investigated. In the first approach, which I've entitled the global analysis, what was done was essentially extracting radiomic features from the PSMA and FDG scans separately and combining those metrics into a single unified metric that was reflective of discordance. This will make sense in the next slide. And then basically testing that unified metric for outcome correlation. In the second analysis, which I've called the local analysis, I try to replicate how discordance is defined in the literature, right, according to mismatched lesions. So I wanted to find a way to automate that detection of those mismatched lesions. And what this eventually led us to do was computing these discordant masks from co-registered PSMA and FDG scans. I'll get into that. All right, so in the global analysis, so as I've said, metrics for both modalities were extracted, namely volumetric features and SUVmean and SUVmax. The SUVmax was not subsequently used. And these metrics were combined into a single unified metric. So if we see here, these were the 5 novel metrics introduced, which, as I've argued, are reflective of the discordance phenotype. Because what every metric is essentially asking is, to what degree is a patient's disease metabolically active rather than molecularly? So as an example, the volume ratio, which is intuitively the easiest to understand, it's going to take the MTV, so the metabolic tumor volume on the FDG scans, and divide that by the total tumor burden on the PSMA scans. So if that ratio is above 1, that's telling us, obviously, that there's more FDG disease than PSMA disease, which arguably is reflective of a discordant phenotype, because discordance is really the FDG disease is more active than the PSMA. So all these metrics sort of take that into account. Let's try to find a way to combine information from both scans. And under univariable Cox regression analysis, only 2 of these metrics were significantly associated with overall survival. For example, the TLG over PSMA SUVmean. So the TLG is the SUVmean times the metabolic tumor volume on the FDG scan. So if that metric is high, it's tending to show that the TLG is high, so the FDG burden is quite active, or that the PSMA SUVmean is low, which means that the PSMA disease is less active. And this presented with a 1.44 hazard ratio. So patients with higher values of this metric tended to have 44% increase in the hazard of death. And indeed, only this metric was able to stratify the Kaplan-Meier curve by a significant log-rank p-value. And so what it's showing us is that patients with a higher value of this metric tended to have worse overall survival than the patients with lower values. And to complete sort of that analysis, I also did what's called a maximal log-rank procedure to try to find the value of this metric which separated the 2 curves maximally. This is 25.7. And in this sort of exploratory analysis, I then assigned a label to every patient as either discordant or not discordant, based on whether they fell above or below this exact value. And so the idea here is that we're trying to see if we can utilize this metric to define discordance, to define a patient as being discordant. What it was found was that the discordant patients, so those above 25.7, had received fewer total lutetium PSMA cycles and had higher baseline PSA levels. And both these things are indicative that a patient's disease is more aggressive. And this latter point has been shown in the discordant literature that oftentimes discordant phenotypes tend to come with higher PSA levels at baseline. So that was more exploratory. And sort of straying away from these metrics, I finished the analysis by combining the information from PSMA and FDG scans, but more anatomically speaking. And this is additional research, but it was interesting findings, because what it was found was that patients who showed bone uptake in both their PSMA and FDG scan tended to have significantly worse overall survival with a really high hazard ratio of 4.02. So what it's telling us is that patients with bone metastases on both scans had much worse outcome. And this makes sense. It's just showing that patient's disease is much more active, really. Okay. All right, and so in the second analysis, the local analysis, the original methodology here would have been to apply the lesion tracking algorithm to determine the appearance of mismatched lesions. And after determining the mismatched lesions, testing them for outcome. Do those patients with one mismatched lesion have worse overall survival? But it was quickly found that across the 49 patients, 36 had at least one segment larger than 50,000 millimeters cubic. What I mean by this is if we look at the image on the left, that segment 38 is so large that it no longer makes sense to try to match it to another lesion in a lesion tracking framework, right? It's more a region of disease rather than an individual lesion. And methodologies, namely 3, were tested to try to break down these really large segments into their individual counterparts. And this was one of the methods. And visually, it seemed acceptable, but it couldn't be quantitatively validated. So basically, I had to treat the segments as regions of disease, which kind of led me to develop a more novel approach at determining discordance. So the novel approach to add this discordance to see if a patient has discordance or not was to co-register the PSMA and FDG scans and create 3 masks. So basically, with the 2 overlay segmentation maps, I computed this sort of called FDG discordant mask, which represented any area where there was FDG uptake, but not PSMA uptake, right? Which kind of replicates the approach taken in the literature. This is an area where we have FDG disease, but not PSMA disease. And so the next natural extension was to actually test this FDG discordant volume for outcome correlation. Namely, 2 things were tested. We asked, did those patients with any FDG discordant volume have worse overall survival? And did those patients with more of that volume, increasing number of that volume, have worse outcome? What it was found was any discordant volume, those patients with any discordant volume had a much higher hazard ratio, 2.86. And on the log scale, so as a continuous variable, increasing number of volumes was also associated with the high hazard ratio. And quite importantly, in a multivariable Cox regression analysis, so taking into account basically all the volumetric features, that FDG discordant volume remained an independent prognosticator of outcome. So that's telling us that this likely does represent a region of discordance. Okay, so really quickly, so in a global analysis, there was the novelty of introduced composite metrics from both modalities, and that metric had emerged as the strongest prognosticator. But I have to note that under multivariable analysis, it actually lost its prognostic ability. So, yeah, take that as you will, I guess, but I can explain this later maybe. And in the local analysis, there was that novel paradigm to actually arrive at the discordant volume. So through registration and then actually extracting information from the discordant volumes, we saw that the number, the degree, and the presence of that discordant volume was prognostic of outcome. And indeed, that hazard ratio of 2.86, which I mentioned before, actually agrees with some of the literature where they show that the patients with one mismatched lesion tend to have a 2 to 3 increase in the hazard of death. Whoops. All right, and future work would be to apply the discordance analysis over time. So this was all done in baseline, but it'd be interesting to see how discordance evolves from baseline to follow-up. And particularly interesting, and this is quite not to do with my research, we were to develop models to predict discordance from PSMA scans alone, because obviously taking an additional FDG scan for a patient is just generally inconvenient, extra radiation, time, money, etc. So in the first part, we focused on the lesion tracking and enabled the near automation of treatment response assessment with a lesion tracking algorithm. And in the second part, we analyzed the discordance, we automated the extraction of the discordant volumes, and that can enable perhaps more personalized medicine and optimize treatment selection in the case of really aggressive disease. All right, and yeah, thanks a lot to everyone here. Great people, thank you.
That's great. Thanks, Theo. It's good to know we're all great people. Any questions for Theo? I have a couple. Yeah, John, will you jump in with the one there?
Sure. Glad I'm not a discordant individual for the room. Yeah, thanks. That was awesome. Yeah, do you reckon you could that lesion level cost function could that maybe be adapted into sort of like confidence metric or something that could be perhaps accompanying the lesion tracking?
In the cost function directly.
Yeah, it's
Yeah.
utilizing the cost functions output for each
Yeah.
lesion or something, yeah.
Well, if you like the variant A dash, right, which computed the fraction of overlap between lesion pairs, I guess it's gonna match a lesion as being the same corresponding if they have the maximum fractional overlap, right? But that fractional overlap might just be like 67%, but that just turns out to be the maximum of all the lesion pairs.
Yeah.
But 67% overlap is not much, so maybe that answers your question. We could attach that uncertainty, say, okay, we made that decision because they have the maximum overlap, but the overlap is only 67%, which is obviously not 100. So that, you know, maybe could be propagated. Or just through the registration. I think that's really the main part.
Yeah.
Yeah. So every voxel comes with like an uncertainty measure due to the registration. And any matching decision made in that voxel comes with that uncertainty.
Yeah, I like that.
I guess following on from that, do you think there are any particular causes of the poor registrations for the cases that did have poor registrations? Like was it patients in different arm positions or something?
That was definitely one factor. Yeah, like significant changes in especially anatomical position. I didn't analyze too closely the cases where the registration was poor.
Same scanner. Same scanner. Same images.
Well, they take on the same scan.
Yes.
It's interesting, you know, you mentioned the future work and looking at the PPP. I think it's a good idea. There's also another traffic light workflow that came out of Louise Ellis' group like a couple of months ago, which is kind of similar to RECIP, but it stratifies into a few more categories than just progressive or non-progressive. So that's definitely one you could test as well. My last question is, how feasible do you think it would be to predict the FDG from the PSMA?
I actually
Since you mentioned that as a
I think it's very feasible. Especially if you begin with the data set where you have PSMA and FDG scans, right? On top of using imaging features, you can also use clinical features to predict that there's going to be discordance. Because in the literature, they show that patients who exhibit discordance tend to have higher PSA levels, tend to have higher glycine score. So you can already use these things to inform the clinician that there might be a discordance, right? So that's one thing. And then using the PSMA scan alone, extract features from it that might tell you that there's discordance. And those features, I think, would be learned through some sort of deep learning method using the two scans.
It's very interesting. Like it would rely on something in the PSMA PET scan being related to, you know, the metabolism of the tumours, right? Which I guess you just don't know whether that's the case or not. So you could potentially build a model, but whether it's just going to overfit to that data set or not, you don't really know. So yeah, interesting.
So yeah, because there might actually be no imaging features, radiomics that can do this. But I think
That's what I mean.
the clinical features,
Like the biology just might not be there.
yeah, exactly. But in terms of clinically, we can already get an idea that there's a greater likelihood that this patient might exhibit like the so-called mismatch lesions.
Quick question. Can I go to slide 24? Control.
Yeah.
I saw the picture and I was wondering if a patient in a small region have really high density small lesions, is the dilation method you mentioned before still working? If we apply the dilation to small lesions really close to each other, are they going to connect with another form of degradation?
Yes,
Impacting the performance of the algorithm?
So it depends what dilation we use. Because as I experimented with the automatic dilation, which is the automatic dilation is going to compute the distance from that lesion to every lesion surrounding it, and then apply a specific radius to it, right? So if all the lesions around it are really close to it, that dilation specific radius is actually going to be much smaller. So it's not going to overlap as much with the other lesions, which is why under automatic dilation, we seem to have like a generally good performance across the categories. But if you apply the fixed dilation radius, no matter if it's small or wherever it is, it's going to be the same radius for every lesion. So then that might impact the performance of the algorithm, which is what we saw in the dilation sensitivity. Yeah.
So for small lesions really close to each other, the algorithm won't do much to dilate the lesion. And the source of error will come from the registry registration because it's so tiny.
Yes. Yeah, that's quite likely.
Mismatch during the.
Yeah. Yeah.
Okay, thank you.
One question sort of similar, and so whether you could have like a lesion size dependent dilation.
Lesion size dependent. Yeah, I guess you could, because sorry, like in this, so this is the automatic dilation formula I'm talking about. That's only taking into account the distance between lesion I and J. So I guess, yeah, we could maybe explore having an additional step to take into account. If it's a small lesion, maybe bigger. Yeah, or even actually reduce the dilation radius. Oh, no, sorry, of course, increase it, yeah, to better account for the misalignments during the expansion.
A very quick question.
Sure.
So in some region you have, FDG absorption, but not PSMA absorption. Do you think those region can definitely have metastasis, prostate cancer or some other cancer?
So, sorry, can they,
Or prostate cancer metastasis, or might be some other type of cancer?
right, I don't know the answer to that question. I've assumed that I say.
I know, but sometimes it might happen.
They are probably, I mean, the data I was working with, probably most likely 100% prostate cancer lesions. Because it is just a fact that when they're really aggressive adults, the prostate tumors will tend to uptake FDG. Yeah.
That's crazy question.
It's there.
Excellent. All right. Thanks, Theo. Well done.
Thank you very much.
And last one for the session now.